The technology that we're probably the most excited about is what we call PGT, or pre-implantation genetic testing. And I know that there's a lot on the internet about different types of PG something, so what I'd like to do for a moment is really just describe the differences. PGT, or pre-implantation genetic testing, has two components. PGD, which stands for pre-implantation genetic diagnosis, and PGS, which stands for pre-implantation genetic screening. PGD is a technology that we use when we know what we're looking for. So for example, we know that we've got a couple, both of whom carry a gene for the same disorder. So for example, those are called autosomal recessive disorders. We can also screen for sex-linked disorders. We can also screen for some rare disorders that are autosomal dominant. But we know exactly what we're looking for. So when we examine the DNA of an embryo, we know exactly the sequence to look at. We know exactly the chromosome to look on. So that's really what PGD is. PGS, as I said before, stands for pre-implantation genetic screening. Very different. Here, what we're really looking for are abnormalities in chromosomal number, something that we refer to as aneuploidy. So every cell in the human body, with the exception of eggs and sperm, have 46 chromosomes. There are 22 pair of autosomes, numbered 1 through 22, and then there are 2 sex chromosomes. So a female has 2 X chromosomes, a male has an X and a Y chromosome. With PGS, we can evaluate embryos for aneuploidy, where they have any number of chromosomes other than 46. We can also determine whether pieces of those chromosomes have changed places, what we call a translocation. And those translocations can be balanced. In other words, that embryo has the exact normal amount of DNA, even though maybe 2 sequences have switched places. They may have even switched places on 2 different chromosomes. Or they can have what's called an unbalanced chromosomal arrangement. And where they have this unbalanced translocation, there's an extra piece of one segment and 1 too few pieces of the other segment. And when they have an unbalanced translocation, those embryos are much more likely to result in miscarriage. We can identify which embryos are chromosomally normal. We can identify which embryos are not chromosomally normal. And what that allows us to do is not waste the patient's time and money transferring embryos that have abnormalities that are not compatible with life. So when we determine that an embryo has an abnormality that's not compatible with life, we can discard that embryo. That then allows us to focus on transferring embryos that are chromosomally normal and that have the highest likelihood of being able to result in a pregnancy. One of the things that we determine when we do PGS, by definition, we will know which embryos are male and which embryos are female. So that allows for things like family balancing. It allows for changes in birth order, for example, for couples who we wouldn't be doing this for ordinarily. In other words, we're not doing genetic testing just to determine the sex of an embryo unless there is something like an X-linked abnormality that would affect only one sex. But on the other hand, as an offshoot of doing PGS, we can determine the sex of the embryo. So the other major advantage of doing PGS is it allows us, by demonstrating which embryos are chromosomally normal, to limit the number of embryos that we put into a patient's uterus per transfer. So by only transferring one embryo, something we call ESET, or elective single embryo transfer, we can eliminate triplets, almost always eliminate twins, eliminate the downstream costs of multiple gestation, multiple pregnancy, preterm birth, issues related to preterm birth, hospitalization for preterm labor, neonatal intensive care unit expenses, and it drastically lowers the downstream costs of in vitro fertilization. And the other offshoot of that is that hopefully by eliminating those downstream costs, we can encourage more companies to do the right thing and offer coverage to their employees for assisted reproductive technology.